All right, welcome everybody. Welcome to our October Echo session. Today we are going to hear from Renata again, who is going to be providing the second part of the clinical care session. And we originally were slated to have two case presentations, both focused on PrEP. Our colleagues at Great Lakes Bay in Michigan, unfortunately, we're not able to make it today. So we will schedule theirs for another month. But we are going to hear from our colleagues at La Clinica in Oakland, California, who are going to present. So first, I just want to go through a couple housekeeping and announcements. So please, just reminder to enter your name and organization in the chat box. And if there are multiple of you from the same organization watching this together, please put everyone's name in. Okay, so just a reminder, this is Clinical Care Part 2. So just a reminder, I know I've said this numerous times, but since this is a two-part session, so in order to receive CE credit for this clinical care content area, you need to view at least one of the sessions live. So if you're viewing this live now, but you missed last month's session, then you need to write a reflection in the forum on Moodle in order to receive credit. And if you're watching this as a recording and you attended last month, then you need to remember to view this recording and do a reflection on Moodle to receive credit as well. Okay, so we're just gonna hear the one case presentation from Kathy and Sky in Oakland. Next slide. Okay, so just a reminder about CEs. Hopefully no one is having issues anymore with this, but this is the email that the CE evaluation will come from. And these slides and the recording will be posted to Moodle by tomorrow. So if you need to do a reflection in the forum, you can do so then, and you'll have a week from today to do that. I also wanted to make sure that you were all aware that the call for abstracts for our national convention is now open. The deadline is Monday, November 4th. In 2020, we are going to be in Denver, Colorado, and we're actually co-hosting it with our Colorado state affiliate as well. It's going to be June 23rd through the 25th, and I've included the link below if you want more information and to submit an abstract. I will say there's always a lot of interest among our field in this content area. So I would definitely encourage you to submit an abstract and to look at all the other tracks if there's something outside the scope of this area that you'd be interested in submitting as well. Next slide. Okay. All right, so we are very fortunate to be able to hear from Renata again, so we're going to pass it over to her. You're muted, Renata. You're still muted.
Great. Can you see my slides?
Yep.
Perfect. This is the second part of the series, and I'm going to spend part of my time focusing on some updates around sexually transmitted infections, and most of my time we'll go through that very quickly, and then we'll spend a lot of time on PrEP. So I'll review the CDC control, CDC recommendations for screening, as well as discuss populations at risk for HIV and recommendations around pre-exposure prophylaxis, discuss some barriers you all may be experiencing and how to address some of those barriers. As we know, STDs are quite common in the United States. And young people people, as shown here on this slide, actually account for most of the new HIV infections as well as STD infections in the United States. So what you can see here is that youth disproportionately bear a burden of sexually transmitted infections. And as shown here in purple, for gonorrhea and chlamydia, they account for 60 to 70% of all infections with gonorrhea and chlamydia. A lot of those are asymptomatic, and so because youth don't know they have an STD, they often pass it on to other partners. There are concerns here at the bottom. This is an infographic from the Centers for Disease Control and Prevention, just highlighting some of the unique factors that place youth at risk for sexually transmitted infections. So we'll go back to our case. You met Erica the last time. Now she comes in and she has vaginal discharge. And the question always is, do I need to perform a pelvic exam? Because she's symptomatic and sexually active, she would need a pelvic exam, because at this point, it would no longer be a screening exam, but a diagnostic exam. And so for a symptomatic exam, you would need to perform a speculum exam. This is to remind us that from a vaginalis perspective, trichomonas, excuse me, makes up a very small proportion of all vaginitis or vaginities. Whereas shown in blue are infections, some of which we have names for and some of which we don't. And so you see that these account for many more visits than trichomonas. This slide shows the presentation around different vaginitis. So typically we think about bacterial vaginosis, which comes from Gardnerella vaginalis, as well as Trichomonas vaginalis, and then Candida vaginitis. This is shown here as Candida albicans. But what this reminds us of is that usually BV presents us this fishy odor that results from the overgrowth of bacteria, typically anaerobic bacteria. So you lose all your healthy bacteria that's normally in the vagina, and then there's this anaerobic bacteria that overgrows as a result. And this actually is associated with, it's not necessarily considered a sexually transmitted infection. However, it does predispose individuals to risk for sexually transmitted infections, including HIV. And so while we don't always treat BV, it is associated with STI acquisition. And so in certain populations, particularly pregnant females, because of risk for early preterm labor, we do actually treat BV even if it is asymptomatic, meaning someone's not complaining of symptoms. Trichomonas, individuals usually present with the yellow-green, malodorous, frothy discharge. As you can see here, it's flagellated protozoa. It is associated with pregnancy complications, including early preterm delivery and low birth weight, also increase with HIV risk, and can cause a urethritis in men. We often don't look for it in men, but it can present as a non-gonococcal urethritis in men. Next column shows Candida albicans or Candida vaginitis, and this is typically the cottage cheese appearance, white, thick, adherent discharge. It's been associated with pregnancy complications similar to the other vaginities, and also increased HIV risk. And so when we think about how we treat these infections, we typically want to, and I just want to point out, highlight a couple things. We typically use Flagyl 500 twice a day for 7 days for treatment for BV, unless we're going to use a topical agent. But there are some alternatives that are used and recommended, especially for treatment failure. And so one thing to think about is tinidazole is another form of, it's a newer antibacterial that actually is used to treat BV. The tinidazole, you could either use 2 grams for 2 days or 1 gram for 5 days for any sort of treatment failure associated with BV. So if someone has come back and they're having multiple episodes of bacterial vaginosis. For trichomonas, if you have someone that you're worried about treatment failure, then you want to retreat with Flagyl, and this time you want to do it for a 7-day course, or you could actually treat with tinidazole or metronidazole at a higher concentration, so at 2 grams once a day for 5 days. As far as Canada, if we typically use diflucan or fluconazole, 150 milligrams once, or topical agents. Certainly, if someone is coming back with repeat infections, I think the first step is to actually culture, to send a fungal culture to the lab to get the speciation of the Candidal species, because some of the Candida can actually be resistant, and some of them can actually not be Candida albicans and not sensitive to the fluconazole. I did want to just highlight there are some newer diagnostic tests that have been approved, FDA approved, for diagnosis of trichomonas. The Aptima test is one that we actually use here that you may also have available, and these are very sensitive and specific. Just to review screening recommendations, screening is not recommended routinely for asymptomatic women. The CDC actually does not routinely recommend screening unless someone is HIV positive. The CDC, however, does recommend trichomonas screening for individuals that are in high prevalence settings, such as STD clinics, correctional facilities, or in individuals that are at risk for multiple co-infections. So multiple sexual partners or a history of an STI. As far as management of sex partners, this comes up frequently. The treatment of partners with bacterial vaginosis is not recommended. It really is dependent on the female's response to therapy. And so there's not been any evidence to suggest that treating a partners actually impacts the likelihood of relapse or recurrence of infection. So treatment of partners for BV is not recommended. Sex partners so if you see someone who has trichomonas, their partners should be treated. And that is a recommended, so there's expedited partner therapy where you can actually provide both the treatment for the individual and their partner, and that's state dependent, but partners should be referred to the local health department for treatment of trichomonas. Treatment of partners for Canada is not recommended. Okay, now because she is 16 years old, she is also at risk for cervicitis. As you may recall, the cervical, the cervix is actually immature during adolescence, and so it goes through a transformative process where the cervix actually matures and becomes less susceptible to sexually transmitted infections. Prior to that, however, before that transformation zone, youth are quite vulnerable to STDs. This is just to remind us of the age distribution of both chlamydia and also gonorrhea. that it's predominantly among adolescents and young adults. And if we look at the incidence and prevalence of chlamydia by race ethnicity, what we see is there are differences by race ethnicity with non-Hispanic Blacks actually disproportionately impacted by both high rates of chlamydia and gonorrhea. Again, I'll show a different graph, I think, for HIV later on. Biggest burden down in the southern states and for both chlamydia and gonorrhea, but you can see everywhere in the country is affected. Now, when we think of chlamydia, chlamydia usually can present asymptomatically. If it does present symptomatically, chlamydia presents with some spotting, may present with some discharge, some irregular menstrual bleeding. For males, it's often asymptomatic, but if there is discharge, it's usually a clearer discharge. Whereas for gonorrhea, you see more of an exudative type discharge, yellow, green pus. Again, just to highlight, these are both often asymptomatic. The preferred diagnostic test is actually the nucleic acid amplification test. And so the vaginal swab is the preferred method for women, followed by cervix. So if you or endocervical, if you do either vaginal swab or endocervical, they're fairly equivalent. Urine is the least recommended because of the sensitivity and specificity. For men, urine is the most acceptable approach. For women, as far as sequelae, we often want to be aware of something called pelvic inflammatory disease. PID is associated with untreated chlamydia and gonorrhea. And PID is quite serious because it can lead to infertility, ectopic pregnancy, chronic pelvic pain, and it could be life-threatening if untreated. So we want to make sure that we don't miss that diagnosis. And then also there's an increased risk for HIV transmission for both gonorrhea and chlamydia. And then men often will present with epididymitis. Some individuals can actually get proctitis as well, and we'll talk a little bit about rectal a little bit later. Chlamydia treatment prescription recommendations for treatment have not changed. There has been some new data that actually looked at meta-analysis of 12 randomized clinical trials, really looking at the difference between azithromycin and doxycycline. What you see here is that they were equally efficacious. Doxycycline was slightly, just marginally superior to azithromycin, but again, there's a little bit of a trade-off if you go with doxycycline because of the duration of treatment. You have to ensure that individuals are taking it, and it is associated with more GI upset, including nausea and vomiting. So there's a little bit of a trade-off. I think that you have to take that into consideration, especially with adolescents. And the recommendation is really to do the directly observed therapy where you have someone there and you can give them the treatment right in your office. There is the newer form of doxycycline, Deroxy, which is associated with less GI distress and can also be used, but it is also more costly. As far as gonorrhea treatment, the recommendations for gonorrhea treatment are a twofold, meaning that you have to have two regimens, the ceftriaxone 250 milligrams intramuscularly plus the azithromycin. Doxycycline is no longer recommended as second-line antimicrobial therapy, and that's really because of gonorrheal resistance to the tetracyclines. So what does dual therapy mean? It really means that we want to actually provide it on the same day, preferably simultaneously or within a 24-hour treatment window, to make sure that it's actually provided, but also to make sure that when you think about the area under the curve or how much antibiotic is needed to get rid of the infection, we want to try to get it simultaneously so we can get rid of it without contributing to any resistance. Alternatives for gonorrhea include cefixime, 400 milligrams orally, plus azithromycin or doxycycline. Now, doxycycline is only allowed for someone who, it's permitted only for someone who has an allergy because of the potential for resistance. And so it's really important that if you do an alternative therapy, and I'll talk about this in a few minutes, that you do a test of cure. So in case of an allergy to azithromycin and doxycycline, then you really need to, in case of an allergy to not just azithromycin, but to doxycycline, then you need to move to some other, or a cephalosporin allergy, you really need to move to gentamicin or gamifloxacin, which would have to be ordered specially. Again, this is just showing sort of the rationale for the regimens, and what you see is how effective they are and efficacious they are, comparing in non-comparative randomized trials. And what you see is that really high response rates in both groups. Now, just to go back to the test of cure, patients that have pharyngeal gonococcal infection or gonorrheal infection that have been treated with an alternative regimen would need to have a test of cure 14 days after treatment. And the test of cure would either be by culture or nucleic acid amplification test. The other cause for retesting or test of cure is really if you suspect treatment failure. So it's always really important to, when you suspect treatment failure, to do both the culture as well as the nucleic acid amplification test. And then also to talk to your local health department, because if it is a chlamydial infection, then you may actually need to do special testing to see if it is a certain serovar of chlamydia that is associated with LGV. There have been cases of cephalosporin treatment failures. The superbug in mostly places outside the United States, but they have had a few isolates that have occurred in the US. And so usually it is due to individuals that have partners that have been in these other locations, and then it's passed from one person to the other. But this is just to remind us to be aware that treatment failures can occur and resistance is out there. So what should you do? Call your local health department, Department of Health, as soon as possible. Culture, repeat the treatment with another agent, treat partners, and then do a test of cure. As far as screening, annual screening is recommended for both chlamydia and gonorrhea for adolescents and young adults. It's really important for males to really consider other sites of potential infection, particularly extragenital sites. And so the CDC recommends that at least once a year, young men who are same gender loving men or report sex with other men should actually be screened for chlamydia and gonorrhea in all the extragenital sites. That's urethral, rectum, and oral. And that's regardless of whether or not they report condom use or condom non-use. And then making sure you screen annually for syphilis as well. We've had a number of syphilis outbreaks here in Baltimore, so it's really important not to miss that. The CDC describes other places that are high prevalent settings where screening should occur more frequently, or more consistently. Let me go back. And these are some of the places where we are. So incarcerated populations, military, as well as patients receiving care, STI clinics. Sometimes schools fall under the purview of STI clinics, and so that would be considered a high prevalent setting. Oh, I see that there's a spelling error, sorry. The U.S. Preventive Task Force actually recommends screening every time someone has a new sexual partner, or they report having more than one sexual partner concurrently within a short amount of time, within 3 months. A history of coexisting sexually transmitted infection, history of inconsistent condom use, and history of exchanging sex for drugs. And then the most recent annual report also identified just screening screening strategies to identify high-risk adolescents. And so there's just been some controversy in this area as far as matching up the U.S. Preventive Task Force with the CDC guidelines. But there are some gaps that occur, particularly at the primary care setting, where we're not necessarily screening individuals in high-risk settings. And so we're missing a lot of youth that we perceive as low risk. So these are my recommendations. So really just understand the sexual behaviors of the individual that you're seeing. If they're having sex with any of the body parts, then that's where you need to screen. And then screen more frequently based on at least once a year, and then more frequently based on number of sexual partners, as well as new partners. Really important to talk about barrier methods, not only during insert of sex with a penis, but also with sex toys. We've had individuals actually transmit sexually transmitted infections between same-gender partners with the use of sex toys. So making sure you talk about that and review how to prevent STIs and the importance of barrier methods there as well. Okay, so another case is someone presenting with a non-healing ulcer and a new onset rash on the trunk. And hopefully you're hearing this case and you're thinking about syphilis, because that's what you want to think about. But there are other causes for genital ulcers, including chancroid, LGV, and trauma. And so just to share with you, there are presentation and examination findings that are consistent with herpes versus syphilis. I do want to highlight just a few things here. So right now, the Centers for Disease Control does not recommend routinely screening for HSV. It's really inconclusive whether or not it actually changes the outcome, particularly around HIV. And HIV transmission, and so routine screening is not recommended. But if someone has had a partner with genital HSV or herpes, if they're a male who reports sex with other men, or if they're HIV infected, you might want to consider it, but it's currently the data is not conclusive in that area. I want to also just mention, as far as syphilis, classically, we've always used the non-treponemal test, the RPR and the VDRL. More recently, there's a two-step process, which is the treponemal test is actually sent first. They're often combined together in the lab. The two-step process happens automatically. And this can actually create some confusion about whether or not someone has syphilis. So if someone has a positive treponemal test, then they reflexively do the non-treponemal test, and that will demonstrate whether or not someone has a new infection versus a latent infection of syphilis. And so the treponemal test will just show if someone has been exposed to syphilis at any point in their life, but it does not show that whether or not they have an acute illness. So you need both the treponemal and the non-treponemal in that order. Just here is the treatment recommendations for both herpes and syphilis. We won't spend too much time on that, but you have that there if you need it. Just to highlight, again, if you are concerned that someone has latent syphilis, then you want to actually treat them with penicillin 2.4 million units times 3 doses. So not just 1 dose, but 3 doses. So weekly for 3 doses. Okay, so he describes that he had sex without a condom 14 days ago. His last HIV test was a rapid test and it was 8 weeks. And so he wants to know, could he have HIV? So the question is always, what test do you order? What's the best test? And I'm going to try to convince you that the best test is to actually order the number 1, which is Determine, or an HIV 1-2 antigen antibody combo test. Now the INSTI individuals are actually using more frequently, particularly in outreach settings and venue settings and some school settings where they may not have the ability to do a serum or blood test. However, the recommendation is to actually, this test, the first test is a little bit more sensitive than the INSTI. So if you had to choose between the two and you could only do 1 test, it would be 1. If there are barriers to getting a blood drawn, however, the INSTI 4th generation, these are both 4th generation tests, it would be appropriate to send. The 3rd test is the HIV-1 RNA qualitative assay, which is not the correct test. Get a quantitative assay if we thought that somebody was acutely viremic or with acute HIV infection. So HIV testing technologies have improved over time. They've really gone from 1st generation to 4th generation. There are some other modalities listed there. Similar to the cell phone, we've really just been able to improve on the technologies we use. Now, this is what I just wanted to highlight. This is the recommended HIV testing diagnostic algorithm. And as I said, the first test is to really do this combination test, the antigen antibody test. And from there, if they're positive, then they do differentiation in the lab to determine what's positive. If it's HIV-1 that's positive, if it's HIV-2 positive, but based on antibody detection, if the individual has both antibodies to HIV-1 and 2, or if it's actually an intermediate test. And at that point, they do a nucleic acid amplification test to really determine if individuals have a diagnosis of HIV or not. If their test is negative, then they do not have a diagnosis of HIV. Now, the question always is, why do the combined test of both a 4th generation that combines both the antigen antibody combination? And this is a wonderful graphical demonstration of why this is really important. 0 is the time of exposure to HIV. And on this axis is really the days following HIV acquisition. And what you see is that if someone is exposed 10 days after being exposed, they have a detectable viral load. So this is where we're worried about acute HIV infection. It can take anywhere between 15 to 20 days for the 4th generation test to come up. And this is what I just wanted to highlight, that the 4th generation serologic or lab-based test comes up earlier, you know, as much as low as, you know, 15 to 18 days before the point of care test. The point of care test, of course, is better than the 3rd generation test. And the 3rd generation test is what a lot of people use, which is the OraQuick. They do the swab in the mouth, the OraQuick. It's a 3rd generation test. And that can take up to about 30 days to actually become positive. Overall, the point here is just to remind you that you do want to do a 4th generation antigen antibody test that combines both the P24 antigen and also the antibody test, and either do the serologic based or the point of care INSTI. Who should be screened for HIV? The CDC since 2006 have recommended that all patients 13 years to 64 should be screened for HIV using an opt-out strategy, meaning you offer it to everybody. And then you really allow the person to refuse. You diagnose, you document refusal in the chart, but you make it routine, because there's really been data that demonstrates that individuals are more likely to be tested if you make it more routine. There are some slight variations based on state laws, but this is overall the standard in the United States. And then you repeat screening at least every year for those that are at high risk. You may actually have to repeat it more frequently, particularly for individuals that are having more frequent partners or new partners, or have had an STI, or young men who have sex with men. So we're going to shift into PrEP. So pre-exposure prophylaxis, also called PrEP. To keep it very simply, PrEP is a preventive method for adolescents and adults who are HIV negative, but they're at risk for HIV. And the purpose is actually to reduce their risk for becoming HIV infected. And if you can think about it that way, it's much more simple, straightforward. It's a co-formulated tablet with emtricitabine and tenofovir, and it's taken once a day. PrEP has been approved in the United States, actually, and worldwide for quite some time. And then in 2018, it was approved based on weight, so that anyone that, regardless of age, if they're 35 kilograms or greater, the FDA approved its use in that population. So that includes adolescents, whether they're 15, 16, 14, it's approved for use in that population for pre-exposure prophylaxis. Just to note that it had been approved for much longer for treatment purposes. So who should take PrEP? If you think of it very simply, I think there are 6 boxes. And in the middle is anyone that does not use consistent condom use. And so if you boil it down, if you see someone that's not using consistent condom use, then they're at risk for HIV. And they should be prescribed or provided information about pre-exposure prophylaxis. Then you can think about other groups. Someone who it may be in a serodiscordant relationship, meaning their partner may be living with HIV, but they don't have a diagnosis of HIV. Someone who has had multiple sex partners. Someone who is engaged in sex in exchange for a place to stay, or food, or money, or sex work. Someone who's had a bacterial STI. So this is anyone that actually has had a recent bacterial STI diagnosed within the last 6 months, and then someone who engages in injection drug use. But again, I think of it more as nailing it down to the minimal, and really, if you're not using consistent condoms, you're at risk for HIV, unless you're in a monogamous relationship. What's the evidence behind PrEP? So the studies have demonstrated that the risk of HIV is reduced by up to 97% when taken regularly. And we'll look at the data just a little bit closer. But overall, it was well tolerated with very few side effects. And this is a summary of the study populations that have really looked at pre-exposure prophylaxis. What you see here is the IPREX study, which a lot of people focus on. The population was men who have sex with men and transgender women that were 18 years and older. Individuals were prescribed Truvada or tenofovir emtricitabine, 1 pill once a day. They also received counseling and very close follow-up and condoms. So overall, there was 44% reduction in incidence of HIV. However, among individuals that had detectable blood levels, it was a 92% reduction, and it increased with this was based on self-reported, and it increased with detectable blood levels or tenofovir blood levels in the individual. And so what you see is that multiple studies demonstrated that it was effective, greater than 92% effective, and more effective with adherence. So as adherence increased, as the blood level increased, then the protection also increased. Let's look at the rates of PrEP use. So about 1 million Americans are at substantial risk for PrEP, and only 10% of them are actually prescribed PrEP. And this is based on recent data that suggests that we're really not reaching, we only have about 100,000 individuals on pre-exposure prophylaxis. And if you break that down by age, most individuals are older than 25 years old who received a prescription for pre-exposure prophylaxis. There are disproportionate rates of HIV that occur among African American same gender loving men. But when we look at PrEP use by sex and race ethnicity, what we see is that disproportionately PrEP users are white and male, and not often females, and not often African Americans or Latino or Hispanic.
Renata, can I interrupt you for a second? Yeah. There was a question on the chat box regarding how do you define multiple sex partners? Is that 2 or more within 3 months, or is there like a definition for what that is?
Yes. So if you have exactly that, 2 or more over 3 months, then that's defined as multiple sex partners. So if someone is concurrent, so it's within 3 months is a period of time that's been defined as a concurrent period. So multiple sex partners during that time is considered high risk.
Okay. Thanks.
So some of the work done by Sybil Holsek has really looked at adherence by race, ethnicity, and we'll talk about different amounts of tenofovir in a little bit, but for greater than 4 doses of tenofovir, emtricitabine is defined as protected levels of tenofovir in the blood. And so what they looked at over time, this is an open label study among adolescent men who have sex with men, really looking at their tenofovir blood levels. And what they see is that overall, at about week 8, levels increased above protective levels, but however, after week 12, levels declined below the threshold for protection. And if you break that down by race ethnicity, what's most striking is that African American males in the groups had sub-protective levels at all time points, meaning that they did not reach protected blood levels for tenofovir. We further looked at this, and what we found was that in addition to Black race having been kicked out of the home due to their sexual orientation, reporting depressive symptoms, low perceived HIV risk, and mistrust of medications, as well as fear that someone else might see that they're taking PrEP, were all associated with not adhering to the medication and having sub-protective blood levels. When we control for all these factors, the 2 factors that remained significant were Black race at every time point and having been kicked out of the home due to sexual orientation. So, which brings up that a lot of the youth that are at risk for PrEP are also very vulnerable. They're experiencing very high rates of unstable housing, substance use, mental health. And so they're going to be coming to you at a very vulnerable period. So let's talk about how to start someone on PrEP. I think the first step is really to assess their knowledge of and attitudes towards PrEP. So what have they heard about PrEP? A lot of people have seen commercials or billboard ads about pre-exposure prophylaxis. They may have a friend that's been on PrEP, but they may also be worried about PrEP. I've heard this from individuals that they may not trust it. So just trying to get a baseline assessment of what they know and how much they know and their attitudes towards PrEP so that you can try to address them. And then discuss perception of risk. Often we find that in youth, their perception of risk often does not match. So while someone says, I'm not at risk for HIV, they've had 3 STDs in the last 6 months, and you know that they're at risk for HIV acquisition. And then identify behaviors that may be putting the participant at risk. Is it numbers? Is it condomless anal intercourse? What are the factors that are putting them at risk for HIV? Is it substance use? It's the combination of all of them. And then discuss barriers around PrEP. So some barriers to consider include insurance barriers, access. I have already mentioned mistrust, negative views towards PrEP. So some of you may have heard of something called Truvada whore, meaning that some people perceive if you're going to take PrEP, then you're really going to be out there and having a lot of sexual partners and very loose, and that can be detrimental towards perceived benefit of being on PrEP. And then some people have concerns because they've seen ads about side effects about PrEP, so they may not trust the medication. There are barriers around parental consent and concerns of confidentiality, which we talked a lot last week as well. So here in our program, the PrEP is for Youth program, we try to approach this that this is more than just taking a pill once a day. You really have to take care of the individual as well and try to address their coexisting needs. And so we try to use a multidisciplinary approach, working with our social workers and our navigators. We have a navigator on site, trying to plug people into mental health treatment if necessary, really trying to think about a harm reduction approach, understanding better why individuals are not using condoms, for example, why they're not engaging around PrEP, to really try to use a stage of change to try to engage them around PrEP, to move them along the continuum. And then really addressing their other needs that may be impacting their ability to get onto PrEP. At the first visit, you want to actually get a 4th generation antigen antibody test. The algorithm, as well as the guidance, recommend that a test should be done within 2 weeks. So if you are outside that 2-week window period, I would recommend that you repeat that test. Now, I want to say it is important. We're moving towards trying to get people onto PrEP sooner rather than later. So if you have someone that you, the HIV test 2 weeks ago or greater than 2 weeks ago, but they're there and they want to get on PrEP, you can send that test, start them, and then follow up with the results, and then alter the regimen if necessary. You want to get a creatinine at that baseline, check for hepatitis A, B, and C serologies, check for gonorrhea and chlamydia at all 3 sites, as well as screen for syphilis. You want to get a urine pregnancy test in females. PrEP is allowed in pregnancy, but you should be aware that the individual is pregnant before starting the medication, and get them plugged into necessary care. And then once you start them, I typically like to see people fairly closely in the beginning, so in a month, and I might see some people even more frequently than that, just depending on their needs. And then you want to try to space them out to every 3 months, and provide them with a 90-day supply if they are able to stretch out to every 3 months. At each appointment, it's really important to sort of talk about difficulties with adherence, ask about adverse effects or any side effects, screen for STIs, provide risk reduction and counseling, and then every 3 months, really repeat testing for HIV and a pregnancy test for women that are actually on pre-exposure prophylaxis, and then at a minimum every 6 months, screening for sexually transmitted infections. I often find that I talked about the STI screening recommendations, and I find that people have had multiple or a new sexual partner, so I actually end up screening them probably more frequently than every 6 months because of their risk for STIs and HIV. And then once a year, screening for hepatitis C. So we're going to talk more specifically how to address some of those barriers. Some of the biggest side effects of PrEP include GI discomfort, nausea, some diarrhea, some gas or indigestion, as well as headaches. And so I always tell people that the nausea and feeling sick to your stomach is the most common side effect, but it usually resolves within 1 to 2 months. So I will empirically prescribe someone an anti-nausea medication for the first few doses and suggest that they take it for the first week of being on the medication and then stop it and see how it goes. Also, side effects that have been noted and focused on, particularly in the media and the news, is renal toxicity and bone mineral density, decrease in bone mineral density. And what the data has demonstrated is that really there's been mild, non-progressive decrease in creatinine clearance, as well as bone mineral density, but that both of these were reversible. So once the medication was stopped, it went back to normal. To follow the creatinine clearance, or the creatinine at least, because some people do, and some people are prone to renal insufficiency. So you don't want to miss that. So I don't want to negate that that can happen, but it's rare. It's not it's not common with every prescription provided. As far as minor consent, again, just reminding you that minors have the capacity to access preventive services. There are 6 states as shown here in this purple. And then Maryland actually is now a purple state that have explicit rules that allow for minors to consent for preventive services, including PrEP, without parental consent. But no state explicitly prohibits minors access to PrEP. So there's no state law that has explicit language around that, or any other HIV preventive methods. So there's no law that says you cannot provide prevention for HIV. And then what I find most helpful when you're addressing minors that are coming in with needs or that are trying to get tested for HIV, and you know that they might be at risk for HIV, I make PrEP as part of that conversation. So, you know, as part of your regular care, we're going to routinely test you for HIV and have a conversation about that. And then as there's a medication that can prevent you from acquiring HIV. I'd like to talk to you more about it. So by partnering them together, it makes the conversation much more routine. I have had parents ask about PrEP, and I talk to them just about, you know, normal adolescent development, and some adolescents don't make good decisions, and let's protect them as best as possible to prevent them from HIV, and not necessarily specific to the adolescent's history, their sexual history, or sexual behavior, but keeping it much more broad and general and not specific to the adolescent. As far as access is concerned, the cost of PrEP is covered by nearly all health insurance plans. Truvada has a co-pay assistance program, and the card is shown here. The last time I checked, it was still for individuals that are 18 years and older, so I don't think they have changed that yet. I'm hoping that they're going to change the copay card to include individuals that are less than 18. They also have a Gilead medication assistance program. The number is shown here for individuals that don't have insurance or are under insurance. Unfortunately, with the copay card, you cannot have Medicaid and use the copay card for the copay with Medicaid. But most Medicaid programs cover tenofovir and tricidebine. There are some great websites to be able to use to find a PrEP provider. The first one is by the Gilead Corporation, and the second one is out of Emory. But you can type in the zip code and address where you are, and it will list all the PrEP providers in your area. One thing I do want to highlight is that as of June 2019, this was recently released and discussed on CBS. I think this article is from CBS Health and Science. But this is just to highlight that the U.S. Preventive Services Task Force actually gave PrEP a grade A recommendation and recommended it for individuals that were 15 years and older, which is great news because this means that policy holders, insurers will have to be obligated to cover the medication at no cost. So I imagine in the next year, we'll start to see more expansion around PrEP, especially from an insurance perspective. There are some provider barriers that you should be aware of, particularly as you're seeing adolescents. And so someone nicely studied, I think this Hart and Cooper nicely studied adolescent providers that were members of Society for Adolescent Health and Medicine. And most of them said that they were willing to prescribe PrEP, but willing to prescribe did not equal actually writing a prescription. And what they found was that actual prescription was associated with having provided non-occupational post-exposure prophylaxis, as well as perception that an adolescent would take their medication, their PrEP medication, and having cared for HIV positive patients. And so a lot of providers are just uncomfortable prescribing PrEP because they may not know about PrEP, but they may also be uncomfortable about that adolescents may be more likely to engage in riskier behaviors. I did want to talk about that because there was a nice meta-analysis about PrEP and on sexual risk, particularly among men who have sex with men. And this is a pooled analysis as shown here. And what you see is that overall the odds ratio was 1.24. So it was not statistically significant to have higher STI diagnoses after starting on PrEP. There were some statistically significant differences around certain types of infections, particularly rectal STIs and rectal chlamydia, as shown here. But the other STIs, particularly syphilis, other sites of chlamydia and gonorrhea, were not statistically significantly increased after being on PrEP. And so what we have to remember, though, is that those at greatest risk have the greatest need. And so what you see here is that individuals that have had a diagnosis of syphilis are 76% greater risk of acquiring HIV. And so, what's striking is that 1 in 15 individuals that have had gonorrhea or chlamydia, particularly men, if they've had rectal gonorrhea or chlamydia, will go on to acquire HIV within 1 year. And so when you think about it that way, we really need to make sure not to focus on whether or not PrEP is actually increasing risk to engage in condomless anal intercourse, but that these are the individuals that need this medication most, and we've got to get them on it. Youth often struggle with adherence. So I would suggest when you're prescribing and giving someone PrEP to also think about pill boxes and alarms. There are mobile applications that are really being studied to determine whether or not those will be helpful to remind individuals to take their medications every day. And then there are other formulations that are being studied. The vaginal ring, the rectal microbicide, and then also injectable PrEP that may be coming down the pipeline in the near future. One thing I did want to just highlight is also how you talk to someone about their protection, their level of protection. So some youth, and I've had one youth that actually seroconverted because he assumed that he could just take PrEP the day before sex and not take it daily. So it's really important to remind people to take, it is recommended as a once-a-day regimen for protection. And for females, they may need up to 20 days before they're protected, 20 to 28 days. And for males, they need at least 4 doses a week to actually be protected. So at a minimum, if individuals could take 4 doses a week, particularly for young men who are having sex with other men, and even higher to reach greater rates of protection. We don't have this data quite yet for trans women because this is still being studied in how PrEP and feminization hormones actually interact and whether or not that impacts drug levels as well. I do want to just say really briefly, when you're thinking about PrEP, you also have to think about post-exposure prophylaxis. So if someone comes in and they've actually had any unprotected anal or vaginal sex where they think they may have been exposed to HIV, or they've been in a sexual assault or been exposed potentially to HIV through needle sharing, drug use or hormones, then you need to think about post-exposure prophylaxis. This is only recommended if someone presents within 72 hours of exposure, so it's only 3 days. So what I like about post-exposure prophylaxis, and the preferred regimen is the best regimen, and I like to use the tenofovir and gemcitabine or the Truvada plus dolutegravir. It's 2 pills once a day. And then after they've completed the 28-day regimen and have been retested for HIV, then you can actually remove the dolutegravir and just use the Truvada for pre-exposure prophylaxis. So just to summarize, I hope that this is some information, particularly for you as you prescribe PrEP routinely. As you can see, youth are at greatest risk and may have the biggest need, and really trying to use a multidisciplinary approach that addresses all those other factors that impact risk for HIV will have the longest lasting effect. Thank you. This is some pictures when we're outreaching, trying to reach people in the community around PrEP and the services we provide here. I'll take questions. Do you want me to stop sharing? Oh, you're muted.
Oh, sorry. No, just keep them up in case anyone wants to refer back to specific slides. There were some questions on the chat. So if folks who had questions on the chat, if you want to ask them now.
Okay, Renata, can you hear me?
Here's as well.
Kathy Rose,
Yes.
Can you hear me?
Yes.
Okay. I was wondering what you prescribe. You said you routinely prescribe like anti-nausea medicine for people who are starting Truvada. What do you prescribe?
So if the insurance company covers it, there's this Zofran disintegrating tablet, which I like. And then if not that, then just Phenergan. The Zofran, why I like that is because it can just go right underneath the tongue. And you can tell people to take it, 15 to 30 minutes before they take their medicine. And then they can just go ahead and take their medication, their Truvada. So with the Phenergan, then you really need it to be in 30 minutes before they take their medicine so that it works. But if they take it at the same time, that's okay too.
And you're talking about oral Phenergan, like I take a pill before. Okay.
Oral Phenergan, yes. Mm-hmm.
Okay. Thank you.
This is Sarah.
And that's the biggest side effect that. Go ahead, Sarah. Sorry.
No, you can finish what you're. Mine was a different question. Sorry.
Oh, okay. I was just saying that that's the biggest side effect that I note, as far as symptom that people have, and that usually goes away after about a week. But if people continue to have that as a side effect, you can continue to prescribe the Zofran or Phenergan.
Thanks.
Sorry, I had a question on a couple questions. So when we're doing the lab testing, I have always still been doing the RPR for syphilis testing, and I know you mentioned that doing the RPR during their first visit, but then you'd also mentioned doing the FTA ABS or whatever instead first. So how are you doing that? Sorry, and then I have one other question about that.
Yes. Yeah, sure. So the best approach is to do the treponema test first. So that is the FTA or the TPA test. So a lot of labs have switched to the TPA, which is the treponema specific test. Now that is the test. It will tell you whether or not someone has had syphilis, but it won't tell you if it's an acute infection, if they've had it recently, or if they had it a while ago. So then they reflexively do the RPR to show whether or not it is, if they have an acute infection right now. The tricky part, so it's supposed to actually pick up more people that actually have acute HIV or that you can actually monitor. So it's supposed to be a better algorithm. The tricky part of doing it the reverse way is that you will get a lot of false positives, right? Because you're doing the RPR, the non-treponemal test, that will pick up individuals that may be positive, certain conditions, lupus, pregnancy, medications can interact with that test. And so then you have to reflexively do the other test and then figure out, well, does this person really have syphilis or not? Do I empirically treat them? Whereas this, you know that they've had syphilis. You just don't know if it was
Okay.
recently or not. Does that
Gotcha.
help?
Okay. Yes. And then my last question is kind of, so we've had issues with, I even worked at not a adolescent HIV clinic, but even at our HIV clinic, we had challenges with this. Getting the specimen, the tube that you're putting it in, for doing oral or oral, rectal or oral swabs. Sorry.
I'm sorry, go ahead.
No,
I
you're fine.
apologize. Someone came to my door.
No, you're fine. The actual test, when we do either urethral or vaginal or urine swabs, that's pretty standard. But then doing the oral or the rectal, do you know do we need special different tubes and things like that for that? Because in the past that has been an issue of getting the right specimen thing for all of that, that it hasn't been routinely had at all of our clinics.
Yeah, so do you have, what do you use? Do you use the Aptima or what do you use? Do you know?
I don't honestly know. It's just a nucleic. I think it is. I think it's a yellow tube. It goes into this tiny little, they put the urine or the swab into this tiny little yellow tube, and then it's the, the nucleic acid amplification.
Yeah.
Okay.
So it's the same tube as the extrarenal testing is the same tube as the test that you would use for endocervical swabs or for so that's probably the best way. So you can't, so that's why I was asking for Aptima. You have the vaginal swab, and then you have the endocervical swab. So there's an orange tube, which is vaginal. You have white with the blue, purple writing, which is the endocervical. And then you have the urine, right? And that's yellow. So the urine, you pipette it into the tube and you send it to the lab. So you want to use the one that is actually the same one as the endocervical swab. So the one that you would use for endocervical if you're doing a pelvic exam.
And that will work for anal and oral swabbing?
And oral, yeah. Yes.
Okay.
If you tell me which test, who's the manufacturer, I can try to get that more specifically for you.
Well, we can probably look on LabCorp and figure it out too. It's just been one of those things that I don't think that clinics are well, staffed for thinking about, or stocked for thinking about, screening in other areas, and then, and one last question on that then, since you mentioned the vaginal swab, do you ever have people do their own that are uncomfortable? Do you let them, because I've done that for wet preps, but so you do that, just let them do their own and stick it in the tube?
There's actually good data that people prefer to do their self swabs. The swab themselves if you're doing the screening. Now, if someone's symptomatic, I would say you should do it. But if they're asymptomatic and it's routine screening, both males and females, they can do it. Okay. And you just have them inserted about a third of the way on the applicator, and then I always tell people make sure you hit all 4 walls, all the walls, and then you break it off into the tube. just show them
Okay.
those steps. And I'll see if I can send you all, there's some instructions that one of my colleagues over in the School of Nursing had developed around self-swabs, and I'll see if I can send that to you all, get a copy of that and send that to you all. And that may be helpful. Now, because you mentioned LabCorp here, our LabCorp requires they have the vaginal swab, which is different from the endocervical swab, which is different from the urine. And the urine is the yellow, the endocervical is the white with the purple writing, and then the vaginal is the orange. So you would use the white with the purple writing for the specimens.
Okay, thanks.
Renata, can you hear me?
Yes.
Hi, I have a question regarding a patient that I just saw last week. It's going to be regarding creatinine and kind of when to monitor and what to do if there's an abnormal. So this is a young, can you hear me okay?
Yep, I got you.
Okay. So this is a young man. He is 15, MSM, 40 plus partners, inconsistent condom use. He has had multiple STIs, currently positive for gonorrhea, anus, and throat. He also has been, we're monitoring him for his RPR titers because he had a positive syphilis back in December. So I prescribed him with Truvada back in May, and then he was supposed to come into the school-based health center over the summer, but did not come in due to a difficult time getting into the school for transportation. So he has been very inconsistent on taking his PrEP, and then he reports that he self-discontinued it about a month ago. Not really sure why. Said he wasn't really doing anything at that time, so didn't feel like he needed to take it. So he's been off of it about a month, and then prior to that, probably taking inconsistent. He does say that he would like to start again, so I kind of restarted from the beginning and did a BMP and also did his HIV screening. HIV was negative. His creatinine was more elevated than it was. It was slightly outside of normal range, 1.13, and the high end of normal is 1.04 for our lab. Everything else was fine. BUN was fine. Ratio was fine. He admitted he had not been eating well, had not been drinking water, had been popping ecstasy pills, smoking a lot of blunts. And so I don't know if is that just dehydration? Is it too even far, removed from the time he was taking PrEP that we could, you say that Truvada caused the creatinine to become elevated? Could you speak a little bit to if you have had patients with elevated creatinine, what do you do? And when does the risk of kidney injury outweigh the risk for HIV acquisition?
Yeah, I think that's a great question. So I think for this young man, I would, I'd repeat it. It sounds like his Truvada use was intermittent, and that he probably did have an increase in his creatinine. I would think that at this point, it's probably not related to the Truvada because he has not been consistently taking it. So that's why I'd start with repeating it. Okay. It sounds like, even though his BUN wasn't elevated, he could still have some mild renal insufficiency secondary to dehydration. Now, I think that your lab cutoff is much more sensitive than ours. So you really want to use creatinine clearance if you're starting to think about whether or not someone is going towards renal insufficiency. And I say that because, less than, we start to worry if it's above that 1.4, so 1.2 even is okay, 1.3, but if you can actually measure creatinine clearance, because that takes into account if he's muscular, his height, you know, and then you can actually see whether or not if his creatinine clearance is greater than 60, then you can go ahead and use the Truvada. But if it's less than 60, then that would be a contraindication to using it. So I would just, I think at this point, it sounds like he's engaged in risk behavior and is at risk for HIV. So at this point, I think the benefit of Truvada outweigh the risk because his creatinine increased a little bit. It's unclear whether or not his creatinine is secondary to the Truvada, right? So I would start by repeating it. I would, follow him closely and make sure you're getting labs at least every 3 months to see if his creatinine changes. And then just, of course, recommending he drink water and drink enough water and stay hydrated and measure that creatinine clearance. So if it is above, like I said, if it's below the 60 point, then you need to rethink your options. I have, it's not necessarily FDA approved, but individuals, a number of, I haven't had a patient on this, but a number of my infectious disease colleagues have used tenofovir by itself for someone who has had a low creatinine clearance. So Truvada is co-formulated with the tenofovir and emtricitabine. It has 2 drugs. Tenofovir by itself could be used. I think we just don't have the data whether or not if it's as efficacious against preventing HIV than the Truvada. But at least it does provide some protection.
Mm-hmm.
But I think you're far away from that.
Okay.
You haven't gotten there yet.
Good. Thank you so much.
Sure. Were there other questions?
Renata, this is kind of a general question, but some of the general comments and concerns I've heard from our field is just sort of something to the effect of, we don't know what the long-term implications, health impacts of PrEP are, especially in young people when their bodies are going through all these changes anyway. And so that there's some of the hesitancy around prescribing PrEP seems to be around that. So what would you say to that concern?
Yeah, so I think that you're right. I think the tricky part is that we also don't want, anyone to get HIV.
Of course.
So
right.
it does become a sort of a risk-benefit ratio.
Mm-hmm.
So I think on the one hand, we do have years, decades of data for individuals that were prescribed Truvada from a treatment perspective that have done well. And some people have not done well, but for the majority, individuals that had been on Truvada did well, right? And so I think that, and a lot of them were adolescents. So, and they did just fine and they're in adulthood, right? So I think you have to weigh that risk benefit ratio. When you look at those rates of STIs and how many individuals that have an STI, such as chlamydia, gonorrhea, and syphilis, are likely to get HIV within a year, then I think it really makes you pause. And
Mm-hmm.
I think that, for now, a lot of youth need to be on PrEP for that reason, because the risk for HIV is greater. And what the data have demonstrated is that it may be that, it's during this vulnerable period of adolescence, right? So that they don't have to be on it for the rest of their life,
Mm-hmm.
when they're able to make better decisions.
Right.
And the data has suggested that the change in creatinine clearance or the change in bone mineral density is reversible. So it's just like Depo-Provera, for example, in contraception. We know that that impacts bone mineral density, but when people come off of Depo, it resumes back to normal. So, you know, I think that for that reason, you have to think of it in that way, that this may be a temporary measure for right now to protect youth that need it and are greatest risks for HIV.
Okay, thanks.
Were there other questions? Should we go to the case?
Yeah. Okay, thank you, Renata. That was great. So can you click stop share and then Ufoma will take it back?
Oh.
Okay.